Hello, and welcome to the Legacy Education ICD-10-CM Guideline Review Series. I am Tiffany Roach, the coding coach, and I will be walking through the ICD-10-CM guidelines with you. This video will cover the chapter-specific guidelines for Chapter 1, Certain Infectious and Parasitic Diseases, represented by codes A00 through B99, U07.1, and U09.0. This presentation is designed to review the ICD-10-CM guidelines that are effective for both fiscal year 2024 and 2025. There were no significant changes to the guidelines from fiscal year 2024 to 2025. The first topic in Chapter 1 is for HIV. When coding for HIV, you should only code confirmed cases. Confirmation does not require documentation of positive serology, but the provider's diagnostic statement that the patient is HIV positive or has an HIV-related illness is sufficient. When a patient is admitted for an HIV-related condition, the first listed diagnosis should be B20 and then followed by any additional codes for all reported HIV-related conditions. An exception to this is when the reason for admission is hemolytic uremic syndrome. The second topic covers selection and sequencing of HIV codes. Regardless of when the patient was diagnosed with HIV, the time frame is irrelevant to the sequencing of the decision. If the patient is asymptomatic or the provider states HIV positive, known HIV, HIV test positive, or any other similar terms, code Z21 should be assigned. If there are symptoms, the provider states AIDS or HIV disease, or there are any opportunistic infections, code B20 should be assigned. If the patient has an inconclusive HIV serology and there is no definitive diagnosis or any manifestations, code R75 for inclusive lab evidence of HIV should be assigned. If the patient has a previous diagnosis of an HIV-related illness, code B20 should be assigned. Once B20 has been assigned to the patient's record, Z21 or R75 should not be used again. When an HIV infection is present in a pregnant patient and they are being seen because of an HIV-related illness, a code from subcategory 098.7 should be assigned as a first listed code, followed by B20 and codes for any HIV-related illnesses. Codes from Chapter 15 will always take sequencing priority. If a pregnant patient presents with asymptomatic HIV during an encounter, a code from subcategory 098.7 should be coded, as well as code Z21. If a patient is being seen to be tested for HIV, code Z11.4 should be assigned. If there are any associated high-risk behaviors, signs, or symptoms, you should code those as well. Also, if HIV counseling occurs, code Z71.7 can be assigned as an additional code. When the patient returns to go over the results of the HIV test, if the test result is negative, code Z71.7 should be assigned for the HIV counseling. If the results are positive, code as appropriate based on the aforementioned guidelines. If a patient with HIV disease, HIV-related illness, or AIDS is currently managed on antiretroviral medications, code B20 should be assigned as well as code Z79.899 for the long-term drug therapy. When a patient is seen for administration of pre-exposure medication for HIV, also known as PrEP, you will assign code Z29.81. These should be used for patients whose intention is to prevent infection if they are at high risk for getting HIV through sex or injection drug use. If there are any high-risk behaviors for HIV, those should be coded as well. Certain infections are classified in chapters other than Chapter 1, and no organism is identified as part of the infection code. When that happens, an additional code will be necessary to identify the causal organism. You should use a code from B95, B96, or B97 to identify the organism. There will be an instructional note found at the infection code advising that an additional organism code is required. Many bacterial infections are resistant to antibiotics. When it is documented that an infection is antibiotic resistant, A code from category Z16 should be assigned, secondary to the infection code, if the infection code does not identify drug resistance. The next section pertains to coding guidelines for sepsis. When sepsis is documented, you should assign the appropriate code for the underlying systemic infection. If the infection or causal organism is not specified, assign code A41.9. Unless severe sepsis or an associated organ dysfunction is documented, code R65.2 should not be used. If a negative or inconclusive blood culture is present, but there is clinical evidence of sepsis, the provider should be queried for clarification. If the term urosepsis is used, the provider should also be queried for clarification. If a patient has sepsis and there is also an associated acute organ dysfunction or multiple organ dysfunction documented, you should follow the instructions for coding severe sepsis. We will go over those guidelines shortly. If the patient has both sepsis and acute organ dysfunction, but the medical record indicates that the acute organ dysfunction is related to a condition other than the sepsis, you should not assign a code from subcategory R65.2 for severe sepsis. If the documentation is not clear as to whether the acute organ dysfunction is related to the sepsis or another condition, you should query the provider for clarification. When severe sepsis is present, you should code a minimum of 2 codes. The first listed diagnosis should be for the underlying systemic infection, followed by a code from subcategory R65.2. If the causal organism is not documented, code A41.9 should be coded for the infection. Any associated acute organ dysfunction should also be coded. When necessary, query your provider for any clarification needed to code for the severe sepsis. When the term septic shock is used, it generally refers to circulatory failure associated with severe sepsis, and it will represent a type of acute organ dysfunction. The code for the systemic infection is sequenced first, followed by either R65.21 or T81.12. Any other acute organ dysfunction codes should also be assigned. You will find an instructional note in the tabular list next to codes R65.21 and T81.12 that they should not be listed as first listed or principal diagnoses. If the reason for the encounter is for severe sepsis or sepsis, and there is a localized infection such as pneumonia or cellulitis present, you should first code for the underlying systemic infection, followed by the code for the localized infection. If severe sepsis is present, a code from subcategory R65.2 should be coded as a secondary diagnosis. If the patient is admitted with a localized infection and sepsis or severe sepsis does not develop until after admission, then the localized infection should be assigned first, followed by the appropriate sepsis or severe sepsis code. Coding for post-procedural complications should be based on your provider's documentation of the relationship between the infection and the procedure. When sepsis occurs after a post-procedural wound infection, one of the following codes should be sequenced first. T81.41 through T81.43 if the infection is following a procedure. T81.49 if the infection is following an other surgical site. O86.00 through O86.03 if the infection is from an obstetrical wound, or O86.09 if the obstetrical wound is on an other surgical site location. An additional code should be assigned for sepsis following a procedure based on the type of sepsis, whether it is non-obstetrical or obstetrical. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned, with additional codes for any acute organ dysfunction that's present. When an infection is following an infusion, transfusion, therapeutic injection, or immunization, either T80.2 or T88.0 should be coded first, followed by the code for the specific infection. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned, with additional codes for any acute organ dysfunction that's present. If post-procedural infection has resulted in post-procedural septic shock, assign one of the codes mentioned on the previous slide for sepsis due to a post-procedural infection first, followed by code T81.12 for the post-procedural septic shock, along with any codes for acute organ dysfunction. You should not assign R65.21 in this instance. There may be instances where a non-infectious process, such as trauma, can lead to an infection which can result in sepsis or severe sepsis. When sepsis or severe sepsis is documented as associated with that non-infectious condition, a code for the non-infectious condition should be coded first, followed by the code for the resulting infection. If severe sepsis is present, a code from subcategory R65.2 should also be assigned, as well as any associated acute organ dysfunction. If the infection meets the definition of principal diagnosis, that should be sequenced before the non-infectious condition. When the non-infectious condition and the infection both meet the definition of principal diagnosis, either condition can be sequenced first. It is important to understand that only a single code from category R65 can be assigned to an encounter. You should never assign a code from subcategory R65.2 together with a code from subcategory R65.1. It should be one or the other, but never both. If sepsis or septic shock complicating abortion, pregnancy, childbirth, and the puerperium is present, follow the guidance in Chapter 15. If newborn sepsis is present, you should follow the guidelines from Chapter 16. If the reason for admission is for hemolytic uremic syndrome and it is associated with sepsis, code D59.31 should be assigned as your principal diagnosis. Codes for the underlying systemic infection and any other conditions should be assigned as your secondary diagnosis. The fifth section in Chapter 1 is regarding MRSA, or methicillin-resistant Staphylococcus aureus, also referred to as MRSA. When a patient has an infection that is due to MRSA, and that infection has a combo code that includes the causal organism, you will assign the appropriate combo code for that condition. For example, J15.212 represents pneumonia due to MRSA. In this instance, you should not assign code B95.62 for MRSA or Z16.11 for resistance to penicillins as the cause of diseases classified elsewhere, because the combo code includes the type of infection as well as the MRSA infection itself and the resistance to penicillin. However, when there is documentation of a current infection due to MRSA and there is not a combination code available that includes the causal organism, you should code the condition, such as your wound infection, stitch abscess, or UTI, as well as B95.62 for MRSA as the cause of diseases of classified elsewhere. Code Z16.11 should not be used, as B95.62 already indicates the resistance to penicillins. When you see the term carrier or colonization, it means that MSSA or MRSA is present on the body, but it does not cause any illness within the patient. A positive MRSA colonization test could be documented by the provider as MRSA screen positive or MRSA nasal swab positive. When colonization is present, you should assign code Z22.322 if the patient has a MRSA colonization, and code Z22.321 when MSSA colonization is present. It is possible that a patient can have MRSA colonization and an infection present during a hospital stay. In that instance, both code Z22.322 for the carrier or suspected carrier of MRSA and the appropriate code for the MRSA infection can be assigned. For Zika virus, only confirmed cases should be coded with A92.5. If the provider documents suspected, possible, or probable, code A92.5 should not be assigned, but only codes for the reason for the encounter, such as your fever, rash, or joint pain, or if the patient was exposed to the virus, code Z20.821 can be assigned. When coding for COVID-19, you should only code confirmed cases as either documented by the provider or if there is documentation of a positive COVID-19 test. When confirmed, you will assign code U07.1. If the provider has used terminology such as suspected, possible, probable, or inconclusive, you should not assign code U07.1, but you should code for the signs and symptoms that prompted the encounter. When documentation meets the requirement for principal diagnosis, U07.1 should be sequenced first, unless there is another guideline that instructs other codes to be sequenced first. Any associated manifestations should be sequenced second. When the reason for the encounter is for a respiratory manifestation of COVID-19, code U07.1 should be assigned first, and the respiratory manifestation should be assigned as additional diagnoses. Some of the examples of respiratory manifestations are pneumonia, when a patient presents with pneumonia that is confirmed as due to COVID-19, code U07.1 should be listed first, followed by J12.82. Acute bronchitis. When acute bronchitis is confirmed as due to COVID-19, U07.1 should be listed first, followed by code J20.8. If the bronchitis falls under the not otherwise specified category, J40 should be assigned instead. When a lower respiratory infection is documented as associated with COVID-19, U07.1 should be assigned first, followed by J22. If COVID is documented as being associated with a respiratory infection that is not a lower respiratory infection, code J98.8 should be used instead. For acute respiratory distress syndrome, or ARDS, due to COVID, that is documented, assign code U07.1 and J80. If acute respiratory failure is due to COVID, you will assign U07.1 and a code from subcategory J96.0. If the patient presents with a non-respiratory infection or manifestation, such as viral enteritis, you will assign code U07.1, followed by the code for the manifestation as additional diagnoses. If the patient is asymptomatic and there is exposure or suspected exposure of COVID and there is no confirmed test result, code Z20.822 should be assigned. If there is a confirmed case of COVID-19, you will refer to the previous guideline for coding confirmed cases. When a patient presents for screening of COVID-19, including your preoperative screenings, you will assign code Z11.52. When a patient presents with signs or symptoms of COVID-19, but there is not a definitive diagnosis that has been established, you will assign codes for each of the presenting signs and symptoms. They could include, but are not limited to, cough, shortness of breath, and fever. If there is an actual or suspected exposure to COVID-19, code Z20.822 should also be coded as an additional diagnosis. When a patient is asymptomatic and has tested positive for COVID-19, you should see the previous guideline regarding coding for confirmed cases. When a patient has a history of COVID-19, you will assign code Z86.16. For an individual who has previously had COVID and there are no residual symptoms or conditions, and there is a negative test result, you should assign code Z09 for the follow-up encounter as well as Z18.16. If symptoms or conditions related to a previous COVID infection are present, then you will see the guidelines for post-COVID infections, which we will go over momentarily. When a patient presents for antibody testing that does not have a current COVID infection or is not there for a follow-up encounter after a COVID infection, you will assign Z01.84. If the patient is being tested for a current COVID-19 infection, you should see the previous guideline discussed. If it is for follow-up testing, you will refer to the guideline IC1G1J. When a patient has multi-system inflammatory syndrome, or MIS, and COVID-19, you will assign code U07.1 as the first listed diagnosis, followed by M35.81. If the patient has a known or suspected exposure of COVID, there is no current COVID-19 infection or a history of COVID-19, and they develop MIS, you will assign codes M35.81 and Z20.822. If there are any associated complications of MIS, additional codes should be assigned for those complications. When a sequela of COVID-19 develops or associated symptoms or conditions develop following a previous COVID infection, you will assign the appropriate code for the symptom or condition that is related to the previous infection, as well as U09.9 for a post-COVID-19 condition. If the COVID-19 infection is current or active, you should never use code U09.9. If the condition associated with a previous COVID-19 infection is present and the patient develops a new COVID-19 infection, then code U09.9 can be used in conjunction with U07.1 to identify the associated condition that is related to the previous COVID infection, as well as the current COVID-19 infection. Codes for the conditions associated with the previous COVID-19 infection, as well as codes for the manifestations of the current COVID-19 infection, should also be assigned. When the patient has not received a COVID vaccine of any type, code Z28.310 should be assigned. If the patient is partially vaccinated, Z28.311 should be assigned. For more information on your COVID-19 vaccinations, those can be found on the CDC website. As always, thank you for supporting us, and make sure to stay tuned for new videos in our ICD-10-CM guideline review. Make sure to subscribe to our channel so that you can be in the know of our newest videos that are released.